Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Cardiovascular disease claims more lives in the United States than any other disease. There's heart attacks, there's strokes, there's arrhythmia, that the list goes on and on. We're going to talk about all of it this evening. We're going to talk about gadgets, we're going to talk about devices, we're going to talk about ablation. There's electricity issues happening in the heart. During this next hour, we have experts answering your questions about the advancements in cardiac care, specifically at UMC. As you know, this is a live call or a live show, so you can call us with your questions at 881-0013. This evening's program is underwritten by the University Medical Center, and we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing their students with us this evening. And today we have Melissa Huddleston with us, and we also have Allie Willauer with us, and they're going to be the ones that are taking the calls. They're going to write down your questions and then bring them our way, so we appreciate that very much. Also, you know, as you've watched the show many times, I'm sure, over the last 23 years, the El Paso County Medical Society has bringing this program to you for many, many years, and I think it's going to be many years to come as well. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Advancements in cardiac care. I know that this is February, it's Heart Month. We talk a lot about cardiology on this program, and it's one of the programs that there are always questions because people always feel like there's something going on with their heart. Either it's racing or am I not getting enough exercise? So this is going to be a busy night. I hope you guys are ready for that. Are you? Yeah? So we have with me this evening, we have Dr. Debrata, and Mukherjee is his last name, and we've been practicing that a little bit. He's our cardiovascular medicine specialist on the program. And then we have Dr. Moeen Abedin, and he is our cardiac electrophysiologist. So again, you're the guy that makes the toy, not makes the toys, but the toy inserter. So we're going to talk about pacemakers and all kinds of things that helps out with the heart. So on that note, Dr. Mukherjee, if we can start with you, what we like to do for the audience is, you are a cardiologist. And in this show this evening, in Advancements of Cardiac Care, if you can explain to the audience what it is that you do all day, every day, just so that they can kind of get a feel about what you do, and Dr. Abedin will do the same thing with you, and that way you kind of have different questions that will be thrown to you throughout the evening. Dr. Mukherjee?
So I'm a cardiovascular specialist and specifically an interventional cardiologist. What I do is see patients in the clinic. I do cardiac catheterization, which is putting catheters in the heart, squirting contrast to take pictures of the heart. And if there is a blockage, we'll use balloon angioplasty or stents to open those blockages. I also read ultrasounds of the heart and stress test for individuals who may be having chest pain, and we need to assess the plumbing of the heart, or if their heart is getting enough blood supply.
Okay. So a lot of times then you are trying to figure out what the issue is as well, right? So you're kind of in the world of diagnosis.
Yes, diagnosis and treatment with stents.
Okay, fantastic. Dr. Abedin, as the cardiac electrophysicist, it just sounds like a cool, yeah, I'm an electrophysicist. What does that mean? Well, in the world of medicine. Oh, wait, when it comes to the heart. Explain what you do to the audience at home.
So a simpler way to break down the difference between what Dr. Mukherjee does and what I do is he deals with the plumbing and I deal with the electrical system. So I'm the electrician, he's the plumber.
And a lot of people don't realize that the electrical system of the heart is a really, really big part of the workings of the heart. So kind of go on that scale just a bit.
So many arrhythmias, meaning abnormal heart rhythms where a person gets an episode where their heart rate goes very fast, are due to something like a microscopic short circuit in the heart's electrical system, most commonly using parts of the electrical system that are present in almost everyone. And so most of what I do is a procedure called catheter ablation, where we insert catheters or wires from the leg into the heart, find these short circuits, and then burn them with a catheter that heats up at the tip like a cautery. Frequently that eliminates the arrhythmia problem without any further need for treatment.
I'm very interested in that, and the audience knows all of my medical history. It's like if they ever find me dead in an airplane, they're like, oh, I know her, 'cause she talked about this on the show. I have mitral valve prolapse, I have AFib, I've got it all going on. My doctor basically says it's chronic, but it's benign, it's all good. But I'm still very curious about ablation. I know several people that have had ablation and it's just changed their life. And so I'd like to talk about that later. What I'd like to start off with, though, Dr. Mukherjee, we were talking a little bit earlier before the show. We've got a diagram of the heart it's slide number 1 for the folks in the back. And it's a diagram of the heart that has anything and everything on there. And I like to show this to the audience so that we can kind of filter what it is that we're talking about in the different areas of the heart that we're talking about. So Dr. Mukherjee, would you kind of walk us through what people at home are seeing on that screen?
Right. So I'll try to keep it simple. The heart is a glorified pump that works from the moment we are born or conceived to the time we die. So it's a muscle that never rests. It's a pump. It pumps blood. It has 4 chambers. The 2 upper chambers, left atrium and left ventricle, left atrium and right atrium, and 2 lower chambers, left ventricle and right ventricle. Blood from the legs and from the veins comes into the right atrium, goes into the right ventricle, it gets pumped to the lungs for oxygenation, and then oxygenated blood comes back to the left atrium, goes through the mitral valve into the left ventricle, and the left ventricle pumps blood to the entire body and provides the oxygen.
Okay. So it's like in through the right, out through the left.
Right.
Okay, so that's kind of when we're looking at the blue and the red on these different diagrams. That's a lot of what that's about. And again, I'll talk about mitral valves all night long as well.
Right.
So Dr. Abedin, if we can talk with you a little bit. So just briefly, we talked about the electrical system. And you were talking about the plumbing, and you're the electrical guy. So here's my question. Everything in this world runs on electricity. You know that more than most people do because we just assume that it's all, as long as the blood's pumping, it's fine. How is it that some people's electrical systems in their bodies work differently than others? And it's a huge, wide question that can be answered in a million different ways. But why is it that some people have arrhythmia and some people don't? And let's just say the makeup, it's I don't know if there's risk factors, et cetera, but that would be kind of the starting point question.
So that's a pretty broad question.
Pretty big one, I know, yeah.
And I'll take it into, I'll kind of break it down maybe into 2 parts. That there's some arrhythmias that are due to short circuit, most commonly due to a part of the electrical system that somebody is born with. And why they develop an arrhythmia later in life, say in their 20s or even as late as their 70s, we don't understand, you know, if the circuit is there from birth, why does it become active later on?
Right.
We don't really understand why that happens. And then there are some arrhythmias that are due to risk factors, the same risk factors that everyone thinks of for cardiovascular disease that causes, you know, plaques and blockages, meaning high blood pressure, diabetes, smoking. And those arrhythmias we see probably as much or more often than the ones that are due to just a simple short circuit. But we still have to manage and treat them.
So if you could, and pardon my ignorance on this, a short circuit, when you're speaking about that medically in the world of the cardiac care, like a short circuit, and I'm not an electrician, so I really don't know. I just know that you can use too much electricity and a circuit will blow. But in a human being, the short circuit, when you say they can be born with short circuit or not, I'm losing you there. What does that mean?
Okay. So some people are born with extra electrical connections between the upper and lower chambers of the heart. That's a syndrome called Wolff-Parkinson-White syndrome. That's actually relatively rare.
Okay.
And then the normal electrical system has extra parts in most people.
Okay.
You may think of it as kind of a redundancy for safety reasons. So normally the heartbeat originates in the right atrium, which is the chamber Dr. Mukherjee mentioned, where blood returns from the whole body. It then propagates through the atrium, and normally there's one junction box between the upper and the lower chamber. It's called the AV node,
Okay.
which then connects to essentially cables that then activate the ventricles in a concentric fashion so that they're organized. And
That makes sense to me.
and we see
Okay.
that, you know, on the electrocardiogram. We can see the atrium, and then we see the ventricle. Well, that AV node, people always draw it as a circle, but it actually has kind of up to 4 different limbs. And you can get a short circuit that goes between those limbs, and it can drive the heart up to rates up to 200 beats per minute. Usually those are episodic. They're not life-threatening, but they're very
Right.
disruptive.
Yeah, yeah.
And the interesting thing is that these extra components of that AV node, we believe are present in almost everyone. And we think that it's because that system is so crucial that it should have some backup parts, but sometimes you can get communication between them, like a short circuit. That's what I
Interesting.
mean by that.
That makes a lot of sense to me now. Explaining it that way, I can physically see what's happening physiologically in the body. So I appreciate that very much. I'm going to kind of go back to basics, so to speak, Dr. Mukherjee, and if we could talk about the idea that every doctor says to their patients, right? Eat right, lower your cholesterol, blood sugar, et cetera, et cetera. So I'd like to kind of take that mantra of what cardiologists and or what internists are telling their patients, and what is it about all of those things that relate to the heart? So in other words, we're going to start with cardiovascular disease. Someone who's 10 years old is, for the most part, we think, oh, they're healthy, they're fine, their hearts are great. It's not until they hit 20 or 30 and they start eating too much and not exercising. And you know where I'm going with that.
Right.
If you can kind of explain to the audience what that mantra is from cardiologists.
Right, so this is part of what the American Heart Association has come up with, Life Simple 7. So 7 things that are modifiable. There are things we can't change. We can't change our age. We can't change our parents or the genes we inherited. We can't change our gender, which may be a risk factor in individuals, but there are certain things we can do. We can do more physical activity. We can eat better. We can manage our cholesterol or reduce it. We can manage our blood pressure. If we have diabetes, control it. If we are smoking, we can stop smoking. Certainly we can eat better. Those are things we can control. And if we look at the risk factors for cardiovascular disease, these are all high cholesterol, diabetes, high blood pressure, being sedentary. These are all risk factors, smoking. There have been studies looking at which risk factors are the most important, and of those I mentioned, certainly high cholesterol and smoking are the 2 bigger risk factors, with 40% what we call attributable risk with having high cholesterol, and about 30% with smoking. Well, they are a continuum. So somebody who smokes 2 cigarettes a day has less risk than somebody who obviously smokes 20. So there is a spectrum. Similarly, cholesterol levels. The level somebody's bad cholesterol is 200 is going to have a much higher risk than have a bad cholesterol of, say, 110. There are things that impact each other. So eating right, exercising, certainly losing weight will reduce cholesterol, will reduce blood sugar, will probably reduce blood pressure also with a particular type of diet. So these are risk factors that are important in prevention and preventing, as well as individuals who have established heart disease to reduce future risk. You talked about younger population. It's actually interesting that the younger population, there is more obesity now, more diabetes.
Exactly. Right.
In teens and adolescents, there is more kind of smoking with e-cigarettes and water pipes and hookahs. So there is certainly, those will increase their risk, maybe not immediately, but 10, 15, 20 years down the road. So that's where we need to start with our younger people in schools, teenagers and young adults, to make sure they are exercising. 40% of Americans are obese, and about 20% of adolescents and children are obese. So that's
40% of Americans are obese.
right.
That's
this is
a high
national.
number.
That's a very high number.
Yeah.
So that's a modifiable risk. That ties into even among school-going children, only a third do regular structured physical activity. Only a quarter does the amount of exercise recommended by the American Heart Association, the National Heart, Lung, and Blood Institute. They recommend 150 minutes of moderate intensity exercise per week, or
Okay.
75 minutes vigorous exercise per week. So it could be 15 minutes 5 times a week of vigorous, or about 30 minutes 5 times a week of moderate
And this
exercise.
could, and I want to just bring that down to how daunting or undaunting that can be. And it literally could be a 10-minute walk or a 15-minute walk after dinner. And El Paso's got such great weather anyway. I remember years ago, a cardiologist on one of these programs said, just get a dog, because a dog's going to make you go out and walk. And it may be days like, oh, really, do I have to go for a walk? But it's something you have to do.
Right.
And if you can do it at a brisk pace, do that. But it doesn't necessarily mean you have to go to a gym. And the reason we're saying this is that people hear exercise and it's like, oh God, I'm not going to do that. But just walking, parking your car a little bit farther away from wherever you are, and make it a little hurry to get inside the store or wherever it is that you're going. So I like that we're bringing that up. Dr. Abedin, I'd like to, and I know this isn't really in your area, or maybe we can figure out between the two of you, we are going to be getting questions from the audience about different drugs and different medications that people that have high cholesterol are on, people that in general may have a high risk of stroke, etc. Of the two of you, who should I ask those questions of? Because I know that when they start coming in, and statins is going to be one of the big questions. There's some, periodicals out there. There's questions about, are statins good? Are they bad? Are they good for this? But there are side effects. And I kind of want to start with those because I feel like that's the most prescribed medication for cholesterol. So who would like to take on the statin question?
Happy to take it.
Okay, go
and
for
I'm
it.
sure
Dr.
Abedin
Mukherjee
can
and Dr.
chime-
Abedin, feel free to pop in on that.
Oh, okay. So if you want me to get started, statins is probably, particularly the statins we have right now, has really made a major impact on
Right.
cardiovascular risk reduction.
And I apologize, I should have asked this first. So if we can first describe what a statin does in the system, like physiologically, what is the statin medication doing within your body? I guess that's probably where I should start at that.
So we
question.
call them statin because most of them have a name that ends in statin.
Right,
but
exactly.
it is essentially what we call a HMG-CoA reductase, an enzyme that makes cholesterol in the body. It inhibits that enzyme HMG-CoA reductase and will make the liver to make less cholesterol or less bad cholesterol. That's what
okay.
a statin does.
Okay.
And there is a spectrum. There are less potent statins or weak statins, moderate intensity statins, and then high intensity statins.
Okay. And so that's physical. And then when we're looking at just ages, when people are, and let's just say 50, because I just feel like that's just an easy age. 50 is still very young. However, that's kind of the age when things start not falling apart, because apparently that happens at age 35, right? It's downhill from there and it just gets depressing. But age 50 is when people are starting to take things seriously. That's when, okay, now it's time to get the colonoscopy, right? It's time to get the prostate screening. It's trying to get all these screenings. So when someone's 50, my cholesterol, okay, it's 240, let's say. And let's say the LDL is really high, HDL is not so high. So we're talking someone who really is at high risk. Without knowing, and this is something too I'd like to ask you about, without knowing much with what I've given you, are statins automatically prescribed? Are they, first you have to do some research and go inside, do some electrocardiograms, I'd imagine, maybe some ultrasounds. How does one get diagnosed with how they will be treated going forward?
So let me circle back and say that the age that is recommended people check their cholesterol is 25.
Okay.
Because by the age of 25, and when I was at the Cleveland Clinic, we did a study, by the age of 25, these were all individuals who had died from motor vehicle accidents or motorcycle accidents. By the age of 20s, people start developing what we call plaques or cholesterol in their system. So the earlier we start this risk reduction, including lowering cholesterol, the more beneficial it is. Certainly 50 is a good age, but I think based on national recommendation, I would suggest that everybody get their cholesterol checked at least once at age 25. There are individuals who are, again, as Dr. Abedin brought up, individuals are born with defective genes that can have very high cholesterol in their 10s and 20s and would impact people, their risk of heart disease in their 20s and 30s, depending on the kind of disease, the familial hypercholesterolemia. The way we decide statin or any drug is not an automatic based necessarily on just a cholesterol number. Now, the number does matter, but there are literally 4 categories of patients we typically would give statins to automatically. One is anybody with established heart disease or cardiovascular disease. Could be plaque in the heart blood vessels, in the brain blood vessels, in the leg blood vessels.
And that's something so important to say, because the leg blood vessels are a big deal, and people think, well, they're in the legs. It doesn't. It's all interrelated, and that's so important to get across.
I'm sorry for interrupting, but anybody who has peripheral vascular disease or in the legs also has very likely blockage elsewhere, maybe silent. So that's one group. The second group is diabetes is a very important risk factor for having cardiovascular disease. In fact, most individuals with diabetes will die from cardiovascular disease. So diabetes with an LDL number or a bad cholesterol above 130 should get a statin. We also treat with statin anybody with a bad cholesterol number of 190 and above. And finally, there is a risk score we recommend, which is developed by the American College of Cardiology. And anybody whose risk of having heart disease is more than 7.5% over 10 years should be on a statin. So it doesn't mean everybody, but there is a significant proportion of individuals who could benefit.
And risk factors of statins, is that not a...
The statins, like most drugs, I tell my patients any drug that has effects has some side effects. And when you look up or we Google, and many individuals will, you'll see a number of side effects. But in general, in the appropriate patients, the benefits far outweigh the risks of statins.
And that's that question, right? It's the risk-benefit balance there, and that makes sense. Did you have something you wanted to add, Dr. Abedin? It looked like you did. Maybe you didn't.
No.
Oh, okay. I have a question here from the audience, and it's specifically about pacemakers. So I think that's a nice transition, Dr. Abedin, into what you do. Female does not give an age, and she's asking, can you explain what a pacemaker does? And I like that question because we can then take it first of, what is your heart doing that would say, okay, well, maybe it's time for a pacemaker? Let's maybe reverse the question into that kind of a question. Again, there's no age, but in general, just keeping the same rhythm going forward. And I know there's so many different types of pacemakers now too, right? So I'm just going to give that question to you any way you'd like to take it.
Well, broadly, a pacemaker is recommended when a person's heart rate is felt to be too slow, and typically results in symptoms of fatigue, shortness of breath, and even can get so far as having episodes where they pass out. So a pacemaker is a medical device that goes under the skin with wires that go through the veins into the heart, and the pacemaker sends electrical signals down those wires to stimulate the heart to beat.
And the pacemaker, does it do it automatically every time? And
Yes.
Is there, and I think there's another pacemaker, maybe it's not called a pacemaker, but a device that also is inserted into the body when the heart is not, and it's not a constant thing. It's when the heart decides, okay, well now we're going really low, and then something kicks in. I forgot what the name of that device is. My apologies.
No, that's what a pacemaker is. So we program the pacemaker to set the heart rate at a lower limit and say, well, the heart rate will not go below this.
I see.
If the pacemaker essentially then is a timer and it listens. We usually set the lower rate at 60 beats per minute, which is 1 beat every second. So the pacemaker will listen, and if a second goes by and there's nothing that it detects the heart doing itself, it sends an impulse to make the heart beat. And then that timer resets. And the pacemaker is constantly monitoring and then pacing if necessary. And so there are some simple pacemakers that have just one lead to pace the lower chamber of the heart. Then we can get more complicated and add 2 wires, one in the upper chamber and one in the lower chamber, to keep those 2 chambers in sync. And then we have some pacemakers that have actually 3 leads, meaning sometimes the 2 ventricles get out of sync, and that can cause the heart function to decline. And then we can resynchronize the 2 lower chambers by adding a 3rd wire. And you could sort of say that these are different models with different levels of complexity depending on what the patient's problem is. But generally speaking, when you just say what's a pacemaker for, it's to keep the heart rate from going below a certain limit that we can set.
And it's interesting to me that you've got one that has the 3 different wires. So they're in 2 different chambers, and that 3rd wire, again, it's to not have the double beats, or what would that be for?
I can do some hand puppetry.
Absolutely, do some
So,
hand, and there's
you know,
a heart right here.
the
I know
dual
it's-
chamber pacemaker keeps the upper and lower chambers in sync, but
Okay.
sometimes the ventricles, we mentioned right and left ventricle, you know, normally they should contract like this, but sometimes the conduction system that keeps those two chambers in sync gets diseased, and the walls get out of sync like
There
this.
you go. Okay.
And so what we can do is we can pace here and bring it back in sync.
Okay.
And so in some patients who have this walls out of sync problem and the heart starts to enlarge because of it, the response to this kind of three-wire, what we call biventricular pacing, it can be pretty dramatic. 2 out of 3 patients typically improve significantly when we do that.
Nice. So using the word sync an awful lot. Syncope. Can you describe what syncope is?
Sync-
My son is 17, had a syncope incident and completely passed out, you know, busted his head open, everything else. And he's 17. You're thinking, what happened? I don't know. I just passed out. So what is that? And I don't know if there's anything that causes it. He's never had it again. But describe what that was. Just think about me in the ambulance at high school going, what happened? So from
Well,
there.
syncope is the medical word for loss of consciousness, which
That's the medical
people
word for the
dis-
loss of consciousness.
Yeah,
Okay. well,
and
there
loss
you
of
go.
consciousness people describe as the episode where they pass out.
Okay.
So syncope is the medical word for passing out.
So it's not, the way I understood is that either the heartbeat slowed down for a little bit or for a while there was less blood to the brain for a bit, or...
So we differentiate syncope into 2 categories. What we call neurologic syncope, which is essentially things due to seizures, versus cardiac syncope. And then the cardiac syncope we further divide into 2 categories. One where either the heart rate goes too slow or even goes to 0, or the heart rate goes too fast, so a rhythm-related problem. And then the second category is problems with the blood pressure
Right.
getting low.
Okay.
So, and to take a step back, you know, we first want to address whether feel that it's neurologic versus cardiac, and that you can kind of tell from the history of the episode of syncope. You know, neurologic syncope, when we're talking about seizures, people see the person have involuntary
Right,
movements, and then
right.
often there's a period of confusion afterwards that lasts for 30 minutes, several hours.
That was him.
Whereas
Yeah.
cardiac syncope usually does not have this kind of involuntary movements,
Interesting,
but
okay.
also when the episode concludes, the person recovers and they know who they are, where they are right away.
Immediately? Okay.
Usually.
Okay.
Now there's some overlap sometimes, but that's kind of what we use to try to differentiate
if it was
between
neurological
those
or
2.
cardiac. Okay. All of that does make sense. Dr. Mukherjee, let's go back to you and let's talk a little bit about diagnosis. You were talking earlier, either before the show or right when the show started, about just some of the things that the equipment at UMC, for example, what it is that you can use and what you do use on patients to kind of figure out what's going on. And let's kind of leave the syncopes and the arrhythmias out of it just for now in talking about blockages. You talked earlier about plaques, that you know, kids can even have plaque formation. How, let's say somebody's asymptomatic, or I guess they would have to be symptomatic to come see you, right? And maybe you can talk about a case study or 2 without using names as to why somebody would need to see if they've got plaque in their system. If a doctor hears or thinks something, why would they come see you?
So in general, people would be symptomatic, or that would be the rationale for doing something. So there are
Right.
2 reasons to do anything to an individual, is to make them feel better or to make them live longer. Now, most of the time, patients come in with symptoms of heart disease, like could be chest pain, could be shortness of breath, sometimes could be syncope without getting into the cardiac and neurological syncope, but most of the time they're symptomatic. Sometimes it could be severe blockages, but no symptoms, particularly in diabetics, because it affects the nerves of the heart and may not have symptoms, but they may present with things like heart failure or weakness of the heart muscle. And then we would do tests to look at the plumbing of the heart,
Right.
that they may have silent ischemia that may have caused it. And there are many different ways of looking at the plumbing to look at significant blockages. Stress test can be a stress echo, where we put somebody on a treadmill and do an ultrasound and look at the wall motion. We could do a nuclear stress test, where we inject a radiochemical through one of the veins and look at again the resting and with exercise or with a chemical. Could be these days one of the tests that's evolving very rapidly that we are doing at the University Medical Center is a coronary CT angiography to look at the actual heart blood vessels without putting catheters, so non-invasively by using a CT.
Oh,
we can
nice.
look at the heart blood
I would
vessels.
vote for that one personally. So when you're in there, when do you know when it's time for a patient to get a stent? I mean, when there's enough blockage, is there a percentage of blockage in any particular artery that you think, you know what, it's time for a stent? When and how is that diagnosed and decided upon?
So we do stents in two kinds of patients. One is who comes in with a heart attack, and in general they have, I would say majority, 85% have severe blockages, though there is 10 to 15% may not. And usually there's a thrombus on top of the blockage. The other group, the stable individuals, would do an angiogram if they had an abnormal stress test, or if they continue to have chest pain. Sometimes we'll bypass a stress test, take them to the cath lab. In general, a blockage more than 70% tends to affect blood flow. Anything less than 50% does not. And between 50 to 70% we call intermediate. We have devices called fractional flow reserve wire. So we can put a tiny wire, really like a thread, in the coronary blood vessel or in the heart blood vessel and measure some pressures. That tells us if that blockage is indeed affecting blood flow. Either at rest or with exercise, we can give chemicals, and if it is significant, then only we'll stent it.
Okay, and you were saying between 50 and 70%. To me, that seems so high that, and you could be completely asymptomatic and maybe have blockages up to 50, 60, 70% and not know it.
You could have someone could have a blockage of 65%, not affect blood flow to the heart. Actually, with it still in the intermediate, but we tend to test it. Certainly, less than 50% almost never have significant effect on blood flow.
And that's a little scary too. And we talk relatively often on cardiac programs that sometimes the first sign of any kind of distress or any issues that you have heart issues is you have a heart attack. And I'd love for you or Dr. Aberdeen, I feel like there's almost two different disciplines here. Well, there are, but it's cardiology. If you can talk about, we've heard, oh, they had a heart attack, but they didn't know they had a heart attack. That still, as many times as I've heard that and have talked about it on the air, how can one not know that they're having a heart attack? And then days later, they kind of go, it's like, yeah, I've not been feeling good. And then they do the test and it's like, wow, it looked like you had a little heart attack. And then there are the massive heart attacks where either, boom, you're gone, or you're in the hospital, you know what, now we're putting some stents in there because we got some issues. If we can kind of talk about the gamut of how that runs. And to me, I think heart attack, it's serious no matter what. But talk about the gamut of, not small heart attack, but you know where I'm going with that.
Right. So
Okay.
heart attacks are of two basic types. One is called a STEMI, or an ST elevation myocardial infarction. These are really large heart attacks. And then there are the non-STEMIs, which does not cause electrical changes to, or the ST segment to elevate, could have other changes, and tend to be smaller heart attacks in general. There could be large non-STEMIs. The interesting question that you brought up, how or why people have silent heart attacks, is actually quite interesting. About 25 to 30% heart attacks could be silent. There are multiple reasons. One thing, it could be silent. The other thing could be somebody could have ignored the symptoms. They could have attributed, oh, I just worked out, maybe my muscles are sore. The third very important reason is a lot of the studies on heart attacks were done in men, the major heart attacks. So we tend to think that a symptom of a heart attack is this crushing chest pain. So if somebody has neck pain or belly pain or kind of heartburn or jaw pain, and particularly women, they can be ignored. They may think it's not a heart attack, it's something else. So those are all causes that can make somebody either ignore a symptom, and then there is a small group of individuals with diabetes particularly, or autonomic neuropathy, where they again may not have symptoms. They come in and you do an electrocardiogram or an echocardiogram, few days, few months later, and see that they had heart attack.
And see, that again still fascinates me. Cardiac, let's throw strokes in there just for a minute or two. And Dr. Abedin, I'll go with you. There are ischemic strokes, and then there are hemorrhagic strokes. Are either of the two more related to electricity than the other? Does that make sense? And I know strokes are like a blockage. It, either for the most part gets logged in the brain, but then we're also talking about blood clots. But I don't want to leave strokes out of the discussion.
So there's one arrhythmia in particular, which you mentioned, atrial fibrillation, which has as accompanying it a risk of ischemic stroke, specifically due to embolism. And embolism is a medical word meaning a clot that travels from one place to another, in this case from the heart to the head, and resulting in a stroke. So there are some arrhythmias that lead to having a risk of stroke sometimes, but the more common...
And what is it, maybe I can ask it in this way. So if there's an arrhythmia that leads to a stroke, so if I'm going to bring that language down, an arrhythmia that helps cause a clot, and why would that physiologically be happening? Is it because the blood flow is not going fast enough? And I don't know if it's a blood pressure thing, but how does a clot form? Let's go there.
You hit it right on the head.
Okay.
So normally your atrium should contract like this. When it's fibrillating, it's quivering, so then blood can pool in the inside of the chamber, and whenever you have blood that's not circulating properly, it can turn into a clot.
Okay. And this is where blood thinning medications, and I'm not want to name any medications out there too, and when someone is at high risk of a stroke, and again, there are some AFibs that are specific to clots or not, is that something that's common to have a blood thinner, for the lack of another word for that?
Yes, so
Okay.
there's risk factors for stroke in the presence of atrial fibrillation. Those include other cardiac disease, such as coronary disease or heart failure, high blood pressure, age over 65, diabetes, other vascular disease. And so we actually make a risk factor score and determine if the risk of a stroke is worth the risk of bleeding associated with a blood thinner as far as being beneficial.
And the risk benefits, I'd imagine in your discipline, in both your disciplines, that I imagine the conversations that you're having with patients. And on that note, I have actually a question for Dr. Abedin, but Dr. Mukherjee, what are some of the most common questions that patients ask you about? And the reason I'm asking that is that people that are watching the program, just think about the average everyday person who, when they're coming to you, they have a diagnosis of, they've got an issue, let's say they've got some blockages, et cetera. What are some of the most common questions at that point that people ask you?
Still, one of the common questions individuals ask, will the risks with statins? That comes up fairly often. Then we discuss the risk benefits of going with angioplasty with stenting, sometimes surgery versus medical therapy. That's a recurrent conversation with individuals. In the legs also, we talk about when to open up the blockages, what would be the indications versus medical therapy. Those would be the common question, the type of medications we would use, the type of cholesterol lowering, kind of revascularization options, and how to choose them would be the major questions that comes up in discussion.
And I imagine too, and would these be then lifelong medications? And that's something that I'd imagine like once a year they'd go back and check, or how often would somebody come back and just, I always think yearly. You've got to have that yearly re-examination of medications, et cetera. Is that usually how it goes?
At least.
Okay.
I think in cardiology it's a little more often.
Okay, good.
We look at probably at least 6 months, sometimes 4 months, and make sure their blood pressure is well controlled, they're not having symptoms, but they do need, as you appropriately said, periodic checkup to make sure they're taking their medication, they're not having side effects, and if they are having side effects, we need to change the medications.
So blood pressure is something we really haven't talked much about this evening. And the correlation, we talked about cholesterol, high blood pressure, low blood pressure. I know some people are just I'm very predisposed to very low blood pressure. So syncope, the fact that my son had an episode makes sense. His blood pressure is very low. Mine is very low. I'm gardening, I stand up, it's like, I feel like I'm surfing for a bit. I grab onto a tree. When we have high blood pressure, what are the risks there? And easy for us to say, well, bring your blood pressure down. Is it stress related? Is it weight related? Is it cholesterol related? In general, when someone's got high blood pressure and they feel like they're trying to control it, they feel like I'm doing everything that the doctors are telling me, but it's still really high, what do we tell those patients?
I think the target blood pressure, so normal blood pressure is 120 by 80. Now, we don't treat anybody with a blood pressure of 126, but there is an incremental risk once blood pressure is above 120 by 80. Small risk, primarily a risk of stroke. We treat individuals typically with blood pressure more than 140 by 90.
Wow.
So
Okay.
the thing we typically first try, unless somebody comes in with a blood pressure of 160, 170, 180, very high, if somebody is marginal in their 145, 150, we typically try lifestyle medication, lifestyle therapy. Exercising regularly will lower blood pressure, eating less salt, and the foods like avoiding sausage, soups, and things that are very high in salt. There is a diet called DASH diet, which is essentially rich in fruits and vegetables, low salt, whole grains, that can lower blood pressure. But many patients will need medications, either one or more than one medication. The interesting thing, some of these medications, we have to be careful, can cause what we described as orthostasis. So their blood pressure is fine when they are walking around, but if they are lying down for a prolonged time, they get up quickly, or if they're sitting down, they get up quickly, they may feel woozy and their blood pressure may drop.
That would be me as well. Question here from the audience. I am going to give this to Dr. Abedin because I'd like to respect again the questions from the audience. And it's about syncope again. So somebody was saying 95-year-old female. Good job, 95 years old. Hang in there. Love that you're asking questions on the medical show. Do you have to lose consciousness for it to be considered syncope? And it's kind of talking about is syncope more common in older persons? So I guess we talked earlier, oversimplifying it, sure, but anything with age kind of increases all risk factors. But in general, to honor this question, is syncope more common in older patients than younger patients, I should say? Or is it, I mean, again, the heart, everything's kind of starting to not wear out. I'm using the wrong words, but in general.
Well, to the point of the question, we reserve the word syncope for a complete loss of consciousness.
Okay.
But if somebody has an episode where they feel like they're almost going to pass out, but they don't quite, then we call that pre-syncope.
Okay, well, let's use that then as this idea.
So, as far as statistics go of which age group has more common to have syncope or pre-syncope, I'm not sure. I'm not familiar with that data, and I'm pretty sure we don't have a lot of data on a group of 95-year-olds anyway.
Right.
So in these cases, because, you know, episodes like that can be fairly serious, because somebody can fall and hurt themselves, you know, hit their head or break a bone.
Right.
We kind of take each case individually as opposed to trying to group it based on
yeah, nicely said, or one quick question. Question here from the audience, and what is an AVM or a BBB and a BBB? Does that ring a bell to either one of you?
Yeah,
Dr. Mukavi?
AVM is an arteriovenous malformation.
Okay.
Now, the arteries of the body, which are typically red, will carry blood away from the left ventricle and supply the organ. Then they branch into smaller branches called arterioles, and then into capillaries. And then those will supply blood, and then the draining blood is then drained by things called venules, which will reformulate the veins. And arteriovenous malformation is almost like a fistula or a direct communication between the artery and vein, and it will cause enlargement and direct blood going from arteries to the venous side. The worries is that this venous malformation tend to bleed, or they can rupture. BBB is more Dr. Abedin's field. It's bundle branch block.
Well, I love it when a transition happens quite naturally. Okay, Dr. Abedin, BBB, what does that stand for?
So that stands for bundle branch block.
Bundle branch block.
So
okay.
Earlier I mentioned that the conduction system has the AV node and then connects to wires that activate the ventricles. Those wires are the bundle branches, and sometimes one of those bundle branches can become blocked, and it results in an abnormality in the EKG. Now, not every patient who develops a bundle branch block will have a symptom. Most of them are discovered incidentally.
And incidentally, you mean they're in for another issue?
They have some other
then-
thing, and then somebody does an EKG and it turns up.
Gotcha. Makes sense. Question, Dr. Mugavi, how long do stents last? A direct question from the audience.
Right, it outlasts any human being. They're good for about 800 years. They're made of mostly stainless steel.
800 years.
Yeah, they're not going to go away quickly. The worry is that there is tissue, what we call restenosis. Two things to worry about with stents. Sometimes tissue will grow into the stent, we call restenosis, or sometimes people are on blood thinners after a stent, but if they forget or if they're not taking it, they actually can form clot in the stent called stent thrombosis. But the stents are very durable, they stay in the body, and what happens with time? This is essentially a metal mesh. It gets covered with our own cells, so it's called endothelization, and incorporated into the blood vessel.
Okay.
There's a
so
new
it's almost like we're creating scar tissue around
right
the
to
stent.
cover it.
Okay, okay. How often is it that a stent will then create a clot? For example, if you put a stent into an individual, and you were saying follow-up is a big deal, would they need to have some kind of an incident to think, there might be a block in there, there might be a blood clot growing in there, or do you just every couple of years or every so often double check everything and make sure it's fine?
No, we don't routinely do stress test or double check or any invasive test. In general, people or individuals will come back with symptoms if there is tissue growth or restenosis. With the current stents, the chance of restenosis is, when stents initially came out, the chance of restenosis was 20-25, sometimes as high as 30%. But with the current generation, it's in the single digits, 5 to 8%, maybe at most 10%. The risk of clot formation, if somebody takes their medication, is really low, less than 1%.
Okay, gotcha. Dr. Aberdeen, again, nice transition from the audience. Question is, what's the difference between a pacemaker and a defibrillator? So I know that they're very different, but it's nice to know. I mean, it's great that people are paying attention. So we talked about pacemakers, and if you want to just briefly explain what that is again, and then maybe describe what a defibrillator does.
Okay, so a pacemaker is a device that's meant to keep the heart rate from going too low. So if somebody has low heart rate, the pacemaker will keep the heart rate at an adequate level. A defibrillator is a device that is meant to give an electric shock to reset the heart rhythm for an arrhythmia that's too fast. So fast that the heart is unable to pump blood enough to maintain an adequate blood pressure. So, and that requires a lot more energy in order to convert the heart rhythm back to normal.
Okay.
Now, there's overlap because most defibrillators can function as a pacemaker if necessary. But that's the main difference, is that a pacemaker is for too slow and defibrillators for the heart rate being too fast.
Gotcha. That does make sense. We are at a 10-minute mark, so what I want to do, we've got lots of questions left from the audience, but what I want to do is take a second and see if there's anything that we have not discussed yet this evening that you'd really like to get across. I'm going to start with Dr. Mukavi and Dr. Aberdeen. I'm going to end it with you. And then, again, we've got plenty of questions to ask still. So, but there's still sometimes the show ends and you're like, man, I wish I had said A, B, and C. And so that's your shot right now.
So a couple of things. I'd first like to re-emphasize the importance of prevention. Ounce of prevention is worth a pound of cure, and starting early with a healthy lifestyle, eating right, exercising, and making sure checking your cholesterol early on in life, blood pressure, diabetes, not smoking, and particularly with a younger population, e-cigarettes are also harmful, certainly. Things
I'm
like
glad that you're bringing that up, because I think a lot of people don't realize that that's you know, vaping and e-cigarettes. It's like, oh, for some reason, people that know me, my mother died of lung cancer many years ago, and then we passed the smoking ordinance. So to me, that's a huge topic. And vaping and e-cigarettes, and again, I've got teenagers, right? So to me, it's a huge topic that people just aren't talking about yet. So I appreciate you bringing that up.
So I think staying away from those and living a healthy lifestyle will pay a huge dividend in the later in years to come for this our younger generation. One thing, since we're in El Paso, it's interesting. The Hispanic population have more risk factors, but actually have a lower risk of having heart disease and dying. One thing the American Heart Association points out, women in general, but Hispanic women in particular, they take care of their family, but they ignore themselves, and this selflessness carries a price, so they will have heart disease. So again, urging women to certainly continue to take care of their families very well, but obviously take care of themselves, get regularly checked up by a physician, primary care physician, make sure their blood pressure is okay, cholesterol is okay, they don't have diabetes, and take care of other risk factors, find time to exercise, and obviously eat right.
Exactly, and that is true. I mean, once you become a mom, you're just taking care of everybody. So true. Dr. Abedin, how about you?
So my I guess take-home message I would echo what Dr. Mukherjee had to say, which is, by the time somebody has to come see us, we almost say it's too late. I recently was visiting family, and one of them asked me, "What's the most important test of the heart?" And I said, well, really, the most important things are to know your blood pressure, know your cholesterol, and don't smoke. If you want to make sure your heart's healthy, those are the things you do. There's not some other magic test that we need to do to check if somebody's has a risk or is in danger.
Right.
If they take care of those simple things for many, many years, they will do well for many years to come.
Nice. Do well for many years to come. I think everybody would like that. I have 4 questions here, kind of regarding medication, so I'm going to combine several of these. One is I read in an article published by AARP discussing different medications for high blood pressure. And so the questions are, there's ACE inhibitors, there's diuretics, there's beta blockers, and there's specifically one that's VASCEPA, VASCEPA.
VASCEPA. That's not a blood. Right. That's not a blood pressure medication.
Okay.
That's actually for high triglycerides.
Oh, that's high triglyceride. Okay, and so that is not then necessarily a cholesterol issue, or maybe
it's a lipid issue.
It's a lipid issue. Okay.
That's part of the, as you pointed out, there's good cholesterol, bad cholesterol, and then there is fat, which is triglycerides.
I see. Okay, so then let's go back to, and thank you for that, then the beta blockers, or ACE inhibitors, we talk about those. So which medication is the best? And I know we know nothing about this person, they're just reading an article, but in general, again, I was thinking about the questions that your patients are asking you. When they come to you, they hear all these messages, they read magazines, they listen to the TV, they listen to the radio, and it's like all these medications are being pushed out there. Statins is another one too. In general, blood pressure and medications, what is the most commonly prescribed medication? You have to give a brand name, but I'm just throwing that out there.
So the best medication, I would say, is what works for that individual patient, and we're all different. There is a whole field called pharmacogenomics. It's our genetic makeup and determines how we respond. Having said that, the most studied medication for blood pressure are diuretics.
Okay.
And that's the class of medication has the most data on risk reduction.
Okay.
Now the other medications, ACE inhibitors, beta blockers, including calcium channel blockers, are also first-line agents.
Oh, the calcium channel blockers, I forgot about those.
Those are also first-line agents. Now there are certain individuals where a particular medication may work better, like diabetes and hypertension. An ACE inhibitor is a much better drug because it reduces proteins, protects the kidneys. We don't typically want to use often a diuretic or a beta blocker because it may increase the sugar a little bit. But in general, all 4 medications are great medications as long as they're working and lowering the blood pressure. And the most commonly used are diuretics.
And often too, and again, it's so difficult, and I didn't give the disclaimer, often we just get a small amount of information on these cards. You do the best that you can with answering, but at the end of the day, it's you and the doctor speaking about your history, what your comorbidities are, just in general what's going on. And so that is a big question. From the audience, Dr. Abedin, I have not heard this before, but AFib, a male 75 years old feels like his heart goes a little crazy, gets AFib when he eats heavy foods. He does take, oh gosh, I'm not going to be able to pronounce this, the, omeprazole or...
Omeprazole.
Thank you very much. And it does go away. Is this just a stomach acid issue, or could this be something that has to do with AFib? We have a whole show that we've done in the past. It's like chest pain. Is it really chest pain, or is it a issue with the digestive system? I'm just throwing that out with whatever you'd like to answer on that one.
So there's a subset of patients with atrial fibrillation where it can be triggered by gastrointestinal distress,
Okay.
like upset stomach or heartburn. The heart is encased in a network of nerves that, from the autonomic nervous system, the part of the nervous system that controls the things we don't think about. And the stomach and the intestines are also encased in a neural network. We can kind of think of these as almost peripheral brains, and there is some communication between them. That stomach problems can increase the risk of having atrial fibrillation in a subset of patients. That's not unheard
We're
of.
all so very well connected, right, in that way. Goodness. Dr. Movedine, let's talk about Movedine. I just combined both of them together. Mukherjee. What is the max number of stents that can be placed in the heart or around the heart? Question from the audience. And what do you do if you can't place any more stents? Is that when it's time for bypass surgery? Again, we have very little information, but with that.
Well, the maximum number of stents depends on the size of the individual, the size of the heart arteries in general, but you know, when you're going above 7 or 8 stents, I think it's good to look at if that disease is so diffuse, bypass surgery would be a better option.
And so just out of curiosity, how many stents can be placed at one time? Is this when with multiple surgeries going forward, or how common is it to have 1 or 2 or 3 more or 3 stents in one surgery? Does that make sense how I'm saying that?
Right, right. Sometimes the amount of work, sometimes individuals who have the heart has 3 blood vessels. We didn't go into it. The front artery, which is typically the most important, 1 artery on the left, 1 artery on the right. And sometimes there is blockages in all 3. What limits us is the amount of contrast, because if you give somebody too much contrast, which is needed to do the procedure, they may go into renal failure. It's not unusual to put 3 or 4 stents during a procedure. Typical average nationally is about 1.5 stents per procedure, so between 1 and 2.
Okay.
But sometimes the disease in 1 blood vessel is so severe, we may put 3 or 4 stents. It would be unusual to put more than that, sometimes up to 5 or 6 if we really use very little contrast.
Okay, that actually makes a lot of sense. We're running out of time, but I do want to ask this question because I think a lot of people deal with this. Checks blood pressure at home daily. There's no age. It doesn't have male or female. At home, it's normal, but when they get the doctor's office, it's always high. Why? Do you guys get that a lot too? And whoever, Aberdeen, I'm gonna give that to you really quick, and we've got about 30 seconds.
This is an important observation because I think when people come to the office, sometimes they're stressed.
The white coat
the
syndrome.
white coat syndrome,
Yeah.
or they've been in traffic and they're late and so on. So I actually tell patients we care more about what their blood pressure is at home, and that oftentimes if it's high in the clinic and then we prescribe a boatload of medicines and they go home and take all those medicines, then it's too low when they're at home.
Right. And I like that you said that. So what you have at home when you are at normal pace, normal rest, even the middle of the day and your normal work day, that's the important one. I want to say thank you so much. Again, Dr. Mukherjee, goodness gracious, Dr. Abedin, and also I want to say thanks again to our students, Melissa and Allie. Thank you very much for being here this evening. I'm Catherine Berg, and you've been watching The El Paso Physician.